All right, can everyone hear me?
Yep.
Okay. So my name's Jack Morgan. For those who don't know me, I'm one of the PGY2s. My grand rounds today is titled The Lid, and I just want to thank Dr. Kirshner for helping me put this together. Okay, here's just our CME slides, no disclosures, and then I have the barcode at the end of the presentation. Okay, so chief complaint, left upper lid drooping. So the patient was a 26-year-old female who presented to clinic as a new patient for drooping of the left upper lid that began, it sounds like, about a month ago. She was also endorsing occasional double vision and said one of her eyes was misaligned. She noted that her left eye sometimes deviated out. She said her symptoms were worse towards the end of the day or when she was stressed out. And then she described her double vision as typically vertical and binocular. Of note, she denied any other systemic symptoms and said she did not have any proximal muscle weakness nor shortness of breath. Just completing her history. So she had a past medical history of hypothyroidism, GERD, and migraines. No past ocular history. Her medications were levothyroxine for the hypothyroidism, ranitidine for the GERD, sumatriptan for migraines, and then she was on birth control. Allergies, she was allergic to cephalosporins and penicillins, which caused rash. Family history and social history were non-contributory. And the review symptoms or systems was negative, except as gathered in the history. So her base eye exam was completely normal. I'll just kind of point out two different things. So the pupils, like I said, were completely normal. There was no APD. They were equal and round. And then also, although she was complaining of eye misalignment, when we saw her, she was ortho and her extraocular movements were full. We couldn't tease out any latent tropia or phoria on cover and cross-cover testing. And then here's a video I took of her. I want you guys to pay particular attention to the left eye. And if I could possibly have one of my colleagues describe what they see after the video, that'd be great. Could everyone see that? I'm not sure if it played on my end, but I'm not sure if it played on to the audience.
Yep, we can see it.
Okay, I'll play it again. But could one of my classmates maybe describe what they saw?
Yeah. So we're gonna have this external video of this female when she's looking in down gaze, switching to primary gaze at distance. Her right upper eyelid appears to be retracted. The MRD1 seems increased on the right compared to the left. I can't tell if there was lid retraction there as well by the video. I don't think I saw that, but yeah, definitely the right eyelid's a little more elevated than the left. I guess that you could call the left a little ptotic.
Yeah, good. So kind of the thing to look at was if you look at the left eyelid is ptotic, and when she comes, I'll show the videos. I'm kind of explaining it as she looks up. Notice that the left lid kind of overshoots and then it descends back down. Okay. And then I'll just explain these. So this is her in primary gaze, an external photo on the left, and you can see she has this ptotic left upper lid. What we did is we applied an ice bag to the left eye for about 2 minutes. You can see the stain on her mask. And the ptosis is markedly improved. Okay, so just completing the exam. So the right eye, completely normal. The left eye, kind of like we said, ptosis worsened. I guess we hadn't talked about this yet, but it was worsened after 1 minute of up gaze and then improved following an ice bag test. The Kogan eyelid twitch was present. That's what the video was showing. The rest of this anterior segment exam, normal. And then posterior segment exam, both eyes was normal. Do any of the residents want to offer up a differential?
Myasthenia.
Good.
Thyroid eye disease.
Good.
CPEO.
Yeah. Good. Good. Yeah. Okay. Yeah. So this is the differential in wills. Like I think Chris said, yeah, myasthenia would be pretty much at the top of that. Some other things they had to eat Lambert syndrome. You guys are familiar with this. It's a paraneoplastic syndrome, like typically with lung cancer. Kind of causes an opposite pattern of muscle weakness to that of myasthenia gravis. So like, as they use the muscles more, typically they get better like contraction of the muscles. Chronic progressive external ophthalmoplegia. So it's like one of those mitochondrial myopathies that I think typically starts to kind of present in young adults, and it's just ocular muscle weakness. They also had Kern-Sayer syndrome, which I believe is CPEO plus heart block and some other retinal findings. Another thing they had on their differential was myasthenic-like syndrome due to medications. As I'll kind of talk about later, some medications can either unmask myasthenia or cause like a myasthenic-like syndrome. Some other things they mentioned were third nerve palsy, Horner syndrome, levator muscle dehiscence. Someone said TED. A couple other things kind of less likely, idiopathic orbital inflammatory syndrome and myotonic dystrophy. Oh, back a slide here. Okay. Yeah, so my objectives there: discuss the pathophysiology and basic epidemiology of myasthenia gravis. I want to explore the common clinical presentation along with the workup used to confirm the diagnosis, and then examine available medical and surgical management. Okay, so what is myasthenia gravis? It's an autoimmune disease causing variable amounts of fatigue and weakness that tend to fluctuate throughout the day. It is due to antibody-mediated blocking and damage to postsynaptic acetylcholine receptors at the neuromuscular junctions, which therefore reduces the number of receptors available for normal binding during muscle fibers stimulation. So essentially the muscles can't contract as well. I'll have a figure of this on the next slide. And then it predominantly involves the muscles of the trunk, the proximal limbs, the face, and the neck. Like I said, so here's a figure of the neuromuscular junction. On the right is of a normal patient. On the left is a patient with myasthenia gravis. Just to sort of orient you, so up here, this is the axon with its terminal bulb at the end, and then this, I guess, rugated structure down here that's in pink is the muscle. These little green dots are supposed to be vesicles filled with acetylcholine, and then these kind of red dots that are kind of accumulating at the top of these crests are the acetylcholine receptors. So what happens in like normal physiology is action potential is going to be propagated down the axon till it reaches the terminal bulb here, where it will cause like ions to shift into the bulb, which leads to exocytosis of these vesicles containing the acetylcholine. They go out to the synaptic cleft and then bind to the acetylcholine receptors on the muscle, which then causes new ion channels to be placed on its surface with influx of calcium that leads to the contraction. These other little red dots floating around are acetylcholine esterase. They break down the acetylcholine and kind of stop this whole reaction here. So what happens in myasthenia gravis is not only do you have antibodies that block some of these acetylcholine receptors, but they oftentimes damage and reduce the number of acetylcholine receptors. So there's less receptors to even bind the enzyme in the first place. Also, there's thought to be some widening of the synaptic cleft due to the damage from the acetylcholine antibodies, which makes, I think, the signal harder to cross the synapse. Just some continued facts about myasthenia gravis and some epidemiology. So there's 8 to 10 cases per 1 million person per year. So it's rare, but we see it. Women are affected twice as frequently as men, and there are 2 peaks in incidence, one in the 2nd to 3rd decade, and then again in the 6th to 7th decade. I believe in the 6th to 7th decade, men and women are actually affected fairly equally. There's HLA association with B7, B8, DR2, and DR3. B7 and DR2 are associated with myasthenia gravis that occurs in the 2nd to 3rd decade of life, and also with patients who have thymic abnormalities, which I'll mention below. And then B8 and DR3 are associated with the older, like 6th to 7th decade patients. As I've already kind of said, 75% of patients end up having thymic abnormalities seen on imaging. The majority of those are just hyperplasia, but 15% have tumor or thymoma. It's important to note that we think that most of like the autoimmune process that leads to myasthenia gravis actually like starts in the thymus. So it's like a thymic disease. 15% of patients with myasthenia gravis have purely ocular myasthenia gravis, which means that 85%, so the majority of them, do have systemic symptoms or fall into more of a generalized or a more generalized myasthenia gravis. And then of note, 5% of patients have coexistent thyroid disease like our patient had. Now, there are a lot of medications that may either unmask or cause a myasthenic-like syndrome, and this is due to the fact that some medications will actually affect how acetylcholine is released at the neuromuscular junction. I think the classic antibiotic that you may get tested on or see in the books is aminoglycosides. There's some other ones I've just listed here. Some other commonly used medications that can do it are antiarrhythmic or rate controlling medications, which I've listed some off to the side. And then another classic one is penicillamine, used in Wilson's disease, is known to do this. The chemotherapeutic cisplatin can do it, and statins can do it as well. I don't think I mentioned it anywhere in my presentation, so I'll just like briefly say it here. So pediatric patients can get myasthenia gravis. Neonates or newborns can also get it as like a transient myasthenia from like the antibodies traveling across the placenta, which usually kind of resolves early. There's another syndrome though called congenital myasthenic syndromes, and these are not, unlike myasthenia gravis, autoimmune diseases. These are rare inherited disorders that are caused by defects at the neuromuscular junction. Similar to myasthenia, they cause fatigable weakness of the ocular, extraocular, and limb muscles, but once again, they're not antibody mediated, so they're not going to resolve with immunosuppressive therapy, which I'll kind of talk about at the end when I'm kind of talking about treatment for myasthenia gravis. Treatment of this can be done with quinidine, fluoxetine, salbutamol, and then acetylcholinesterase inhibitors. Okay. Anyway, going back to myasthenia gravis, patients are often going to come to your clinic complaining of like pretty specific symptoms. Like a lot of times they'll complain of like droopy eyelids, whether unilateral, bilateral ptosis. They may endorse like double vision that changes on like a day-to-day basis, and they may say their eyes are misaligned. Other things they may complain about to you are shoulder and hip girdle muscle weakness. So things like they may have trouble rising from a chair or going upstairs or doing like overhead activity, like combing hair, just like reaching for stuff off shelf. They may have dysphagia from oropharyngeal weakness, dyspnea, shortness of breath, hoarseness from laryngeal weakness, and they may have difficulty chewing from like masseter weakness. As I've already kind of mentioned, the symptoms are going to be variable and they're going to fluctuate, but are typically worse at the end of the day when a patient is fatigued or after they've been using that muscle group or exerting that muscle group for a while. Symptoms are going to be, usually they'll endorse them improving with rest. And then important for us, 50% of patients that present with myasthenia gravis have ocular symptoms at the beginning, but ultimately 90% go on to develop myasthenia or go on to develop ocular symptoms. Just real quick, on your examination, you're going to see ptosis. You're going to see usually extraocular muscle involvement, but it's highly variable and it can range from things just like a single muscle being involved, so it may appear like a single muscle paresis, to almost like everything being involved, so like a total ophthalmoplegia. You may be able to tease out some orbicularis oculi weakness on exam. And then if you see these patients in clinic over a period of time, what should really like clue you into like myasthenia gravis is the presence of ptosis or like extraocular muscle weakness that tends to fluctuate or doesn't really conform to any regular patterns or even changes between exams. That should make you very suspicious for the diagnosis. Some like particular exam maneuvers you can actually do in office, kind of like what we did. Symptoms, especially the ptosis, will worsen if you have the patient look and upgaze for greater than 1 minute. Another thing you can look for is the Kogan eyelid twitch. That's what we had the video of at the beginning. So you have the patient look and down gaze for about 15 seconds, and then you have them return to primary gaze. And what will happen with the ptotic lid is it will overshoot, and then it will slowly descend back down to like where it previously was. Something we didn't try, but I read about, is you can apparently have patients do these large repetitive large amplitude saccades, and sometimes the eye movements, you may notice them slowing down as you continue to do it. And then of note, to kind of help you differentiate this from other findings or other diagnoses, patients will have a normal pupillary response. Here are just some photos of a patient with myasthenia gravis. You may, if you have a patient, they may present something like this. So on the right, I think there's supposed to be like a slight ptosis. It's kind of hard to appreciate. On the left, the lid is retracted, and this will sometimes occur due to like Hering's law. So that's like also not uncommon to see. On mobility testing, which is down here in this left corner, you can see that the right eye is unable to abduct. And then when they put the patient in up gaze in this bottom right photo, you can see the ptotic lid just gets markedly worse. So the Myasthenia Gravis Foundation of America has come up with a clinical classification for myasthenia gravis based on the severity. It goes class 1 to class 5. Class 1 is going to be considered ocular myasthenia gravis, while class 5 is when a patient is essentially in something called myasthenic crisis, which is respiratory arrest due to weakness from myasthenia gravis. Everything in between here, so class 2, 3, and 4 are just varying levels of weakness. So 2 is going to be mild weakness, 3 moderate weakness, and 4 severe weakness. Also subdivided into group A and B. A just means that the predominant muscles involved are going to be the limb and trunk muscles, while B means the predominant muscle group, the predominant muscle group involved is going to be the oropharyngeal and laryngeal muscles. Okay, so even though you'll probably be like highly suspicious of the diagnosis after the H&P, there's other things you need to do to work up the patient. You can do acetylcholine esterase inhibitor testing, which I'll talk about on the next slide. But so acetylcholine esterase is responsible for breaking down acetylcholine in the neuromuscular junction. So if you inhibit it, more acetylcholine will reside in the junction and will actually improve muscle weakness. So that's one thing you can do to look for myasthenia gravis. 2 kind of easy in-office things you can do is a sleep test and the ice pack test. So the sleep test, you have the patient rest or sleep for like 30, 45 minutes, after which their symptoms should be improved. The ice pack test, like we did, is a pretty fast, easy test. You put the ice pack on the affected eye, and you should see improvement of the ptotic lid and the symptoms in about 2 minutes. Other things you can do, you can get serum testing for the antibody, so the anticholinergic, or you can get anti-acetylcholine receptor antibody testing and the anti-muscle specific kinase antibody testing. And then lastly, if the differential is like still not really like, you haven't really eliminated some things, you can do electromyography. So myasthenia gravis has a very classic pattern. The more the muscle is stimulated, essentially the worse the response is. So in electromyography, you should see a diminishing response the more you stimulate the muscle group. Like I said, so I was going to talk about acetylcholine esterase inhibitor testing. This is something that's fallen out of favor, pretty much due to the adverse effects that can come with the testing. One of the big things about, I guess one of the things you have to really worry about is that acetylcholine works in a lot of different parts of the body. Acetylcholine in the heart actually slows the heart rate. So these patients can go like have really bad bradycardia. It also works in the lungs to constrict the airway so they can get bronchospasm. They get something called cholinergic crisis where they have increased salivation, diaphoresis, and then go on to develop like really bad GI symptoms. Ultimately, patients can have respiratory arrest and syncope with this. So if you're performing this, you really need to have the patients like on a cardiac monitor, and like you really need to be prepared in case like something happens. The 2 tests we're most familiar with, or most people are probably familiar with, are the idrophonium chloride test and the neostigmine methyl sulfate test. Idrophonium chloride test, you inject 2 milliliters of idrophonium, and then you look for resolution of symptoms in about 2 minutes. Positive test is if the symptoms resolve. If they don't resolve after 2 minutes, you can go ahead and inject another 0.4 milliliters 2 more times. And you observe for, I think, another 30 seconds and then another 2 minutes. If symptoms have resolved, then it's a positive test. If they haven't, then it's a negative test. Um, Once again, due to the side effects, you really need to have like the rescue medication atropine on hand in case they start developing those adverse effects. The other test is the neostigmine methyl sulfate test. It's actually an IM test, so you think you would just inject it once along with a dose of atropine, and you wait for about 30 to 45 minutes for the symptoms to resolve in a positive test. Once the diagnosis is confirmed, you need to do a couple different things. One, you need to refer the patient to neurology, even if they only have ocular myasthenia gravis. This is because majority of patients, I think it's over 50%, go on to develop systemic symptoms within the first 2 years. So it's incredibly important to like have them plugged in with them in case their disease progresses and worsens. Other thing you need to do is because there's often thymic abnormalities, you need to order a CT chest to rule out any of those. And then because like they can have coexistent thyroid disease, you need to order TSH with reflex T4. Treatment. So I had this kind of in bold up at the top here, and I just wanted to talk about it first. If a patient ever came to your clinic with like difficulty swallowing or breathing, this could indicate they were having very severe disease like myasthenic crisis and would require hospitalization and intensive care, and possibly would need things like plasmapheresis, IVIG, and intubation. So be like thoughtful of that. I guess if you see a patient in your clinic with this, you definitely want to ask about those symptoms. Okay, kind of just going back to treatment in general though. So the treatment's a little tricky because, the varying severity of myasthenia gravis, like some patients can have very generalized myasthenia gravis with a bunch of systemic symptoms, where other patients can only have, ocular symptoms that aren't too bothersome sometimes. Um, Basically, though, all patients are at least started on acetylcholine esterase inhibitors. Typically, we do pyridostigmine or mestinon. We usually start lower, 30 milligrams PO/TID, and then work up. Like I think the goal is to be about 60 milligrams PO/QID, but it's going to depend on the patient response. The next thing you would do if patients are having I guess their symptoms are refractory to that treatment, or they're having still a lot of systemic symptoms, then you're going to move to your immunosuppressive medications. One of the ones that we've been using for a long time is prednisone. And the way we use it is typically we start patients on low dose prednisone, and then we titrate them up to a high dose until the symptoms resolve. And then we try to titrate it or taper it back down to like 20 to 30 milligrams every other day. The problem with prednisone is that during the high dose period, you can actually push patients into a myasthenic crisis. So you have to be very vigilant if you're using this medication during that time period. Other immunosuppressive medications are gaining favor because obviously they have much safer side effect profile compared to corticosteroids. So azathioprine is probably the one that's most frequently used, 2 to 3 kilograms a day. But mycophenolate mofetil and I think rituximab are also being more widely used. And then lastly, you can do surgical removal of the thymus, which I'm going to talk about in the next couple of slides. So the American Academy of Neurology released an executive summary back in 2016 in the Journal of Neurology. It was entitled The International Consensus Guidance for Management of Myasthenia Gravis. Basically, they described all the different treatment modalities and what patients with myasthenia gravis would best benefit from them. So they summarized, I kind of at the bottom just summarized what they said about thymectomy and myasthenia gravis. So who should get a thymectomy? A thymectomy is like absolutely indicated for all patients with a thymoma. The only caveat being to that is if patients are very elderly or have a bunch of comorbidities and are just not going to be able to tolerate a big surgery like that, then you could consider doing palliative radiation therapy. But otherwise, they need to get a thymectomy. Myasthenia gravis, or I guess thymectomy can also be considered in patients with non-thymomatous myasthenia gravis if they've been failing trials of immunotherapy, have very intolerable side effects due to the immunotherapy, or if they're just like requiring very, very high doses of the immunotherapy. So typically these are going to be, you would consider this more often in patients with the higher severity disease. So those patients with generalized myasthenia gravis with like bad systemic symptoms. But I think it has been done before, much less frequently in patients with very refractory ocular myasthenia gravis. And they made a quick mention of when to do it in children as well. What they said essentially was that you could consider it in children with generalized acetylcholine receptor antibody positive myasthenia gravis if they weren't having any response to therapy. But for patients that had seronegative, so they have like no antibodies, they really suggested that you do like a very, very extensive workup, ruling out things like congenital myasthenic syndromes before you would even consider surgery. Just looking a little bit more at thymectomy and non-thymomatous myasthenia gravis. This was a study that was published in the New England Journal of Medicine back, looks like August of 2016. So this was a randomized, multi-center, I think single-blinded study that looked at thymectomy and alternate dosing prednisone use in myasthenia gravis versus just alternate dosing prednisone use. The two outcomes they were looking at was a quantitative myasthenia gravis score, which is the score that is widely used by providers who treat myasthenia gravis to help quantify their muscle strength. And then they also just looked at the cumulative dose of prednisone used. What they found in the study was that patients had, significant improvement in that quantitative score, and they also required like much less steroid doses after the thymectomy. So it can be very beneficial in patients who even don't have a thymoma. Okay, I'm about done. I'm sorry if I'm running a little bit over, but back to our patient. So we ordered the acetylcholine receptor antibodies and the MuSK antibodies after that first visit. And the acetylcholine receptor antibodies returned at 34%, which 25% is considered, greater than 25% is considered a positive test. At that subsequent visit, we started our patient on Mestinon 60 milligrams TID. We ordered a CT of the chest to rule out a thymoma, and then we referred the patient to, or the patient was already referred to neurology by primary care at this point. At the visit following that, she said her symptoms were kind of maybe slightly improved, but mostly unchanged on that Mestinon dose. The CT chest came back significant for thymus gland enlargement. It was kind of a vague call. They said it could be hyperplasia, it could be a thymoma. At that visit, we ended up increasing her Mestinon dose up to 60 milligrams QID. For some reason, and I couldn't figure out exactly why, I think it was just to further evaluate the area. Neurology ordered an MRI, MRA. Unfortunately, it's an outside neurologist, so I couldn't look up the records in Epic. But and then we placed a referral to CT surgery for further evaluation. Here was just the photo of the CT that I took. Once again, radiology didn't really like label a specific slide or anything, but they just said there was soft tissue thickening in the anterior prevascular mediastinum. So just kind of like right in this area, they just kind of mentioned this thickening, which they weren't sure if it was just hyperplasia or if it was also, or if it could be thymoma. So those are my sources. And then that's the barcode for the evaluation. Does anyone have any questions for me?
Dr. Eustace, a few comments. A good presentation. I think if you don't think about myasthenia, you're not going to make the diagnosis. So you think about it when you have multiple muscle weaknesses that don't make sense. That's very simple. The lady probably had a vertical deviation, and the way I diagnose it is I think the best way is with a vertical Maddox rod. We'll identify small, possibly intermittent tropias or forward deviations. So in the muscles that are involved, extraocular muscles, it's the same as thyroid, but it does the reverse. It causes weakness rather than tightness. So it's inferior, medial, superior are the three muscles that generally are weak, but any of them can be weak. So other things to say is that mestinon doesn't work for strabismus. I think that my theory, I haven't seen this written, but the receptors are damaged in myasthenia, and even if you bump up the acetylcholine, the muscles do not work. And so you give them a go, treat them. The ptosis usually gets better, but the strabismus does not. So for the boards, they say don't operate on mestinon. On myasthenia patients, but that's BS. You can operate on these people. I've operated on countless numbers of them and helped them. But you do that after they fail with the medical treatment, whether it be mestinon, steroids, or something else, or thymoma. But once their deviations are stable, they can be operated on. They're not that easy to fix, but you can help them. So that's basically it. I know we're a little bit over time. Anybody have any questions?
This is Kate Fitzmaurice. Just a few quick points. A lot of times, I've had patients intermittently complain of double vision. All the tests are negative, especially with ocular myasthenia. The blood tests are negative. And 10 or 15 years later, when you repeat the test, the blood test is positive. Also, I think it's important to talk to the patients who just come in with double vision, because as you know, they can go to general, and tell them if you have shortness of breath or difficulty speaking, you need to go to the emergency room. I had one patient who started out with double vision. Of course, you can't get a neurology appointment immediately, and this patient ended up in the ER 2 weeks later, and she went into general, and she actually died. But the family knew to bring her. She went to a crisis. She was like very elderly. Knew to bring her to the ER. So they might not think, I'm having difficulty speaking or swallowing, breathing, and they might not think it's connected to their double vision. So I think it's important to educate the patients to think of the possibly low risk, but it could happen. If you experience, go to the emergency room.
Absolutely correct. I tell it's usually swallowing. It's double vision, ptosis, and then swallowing, and then it's breathing. So that's the order of loss of function. And I tell them exactly the same thing. And I don't know how many times patients have wound up in the ER and maybe been saved because they had the right advice.
All right, great. Great presentation, Jack. Can you stop sharing your screen so Tommy can share his?
Okay, can everyone see that?
Yep.
Okay. All right, so the title of my grand rounds is Dots, Spots, and Massive Lumps. And I just want to thank Drs. Reynoso and Dr. Doss. This is actually a patient of Dr. Reynoso that was seen in clinic. This is my CME information. I credit ACGME stuff. I have no disclosures. Okay, so let's start with the case. So this is a case of a 13-year-old female who presented for routine follow-up following treatment for flashes and floaters. She was originally from Honduras, moved to the US as a toddler. She originally presented to Dr. Reynoso's clinic in 2015 with floaters of the left eye. Was found to have a localized retinal detachment in that eye and treated with barrier laser retinopexy. She was also noted at the same time to have a tear of the right eye, and that was also treated at the same time. Her vision had been stable since that time, but she also she endorsed some other systemic symptoms. In review of systems, she complained of this sort of intermittent kind of central chest discomfort when she takes a deep breath. She says the pain and discomfort kind of gradually dies down on its own. There's no other associated symptoms. Nothing makes it better or worse. No relationship with any other medications or activities. Past medical history, she had a history of scoliosis. She also has a history of a tumor removal in 2010 in her stomach. She also had a history of scoliosis, lumbar spine surgery in 2014. No significant family history was known. No social history. Meds she takes topiramate, which is a medication she takes for migraine headaches. So on her exam, her right eye, she's 20/30, pinhole in 2025, left eye was 20/30. Her ocular vital signs were otherwise unremarkable. Anterior segment exam of the right eye was unremarkable. On the left eye, she had a finding on her iris. I'm going to show you some of her anterior segment photography. I'd like one of the residents to give us a reading of these photographs. These are all photographs of the same lesion in the left eye, and the shadows are just artifacts.
Look. So there.
So these are color fundus photos. On the left eye looks like. So the first picture on the left tells like a. I think it was like a white hypopigmented lesion on the iris, kind of at the 2 o'clock position. Yeah, I think there's just that one lesion that I'm seeing.
Okay. All right, great. So we have a lesion, like Luke just said. You notice that that's correct. There's a lesion there, the supratemporal iris. We'll kind of describe it at this kind of solitary round. It's hard to see from the photograph, but it's actually slightly elevated in real life. It's kind of a little bit nodular, yellowish white lesion. It measures just short of 0.5 millimeter, so about 0.3 millimeters on the iris. Okay. Can any of the residents give us a reading of the dilated exam here? These are optos color fundus photos of the right eye. Anyone?
Is Banks here? Chris?
Give it a try.
Okay.
So this is a optos of the right eye. The media looks clear. The disc looks sharp. The vessels look good. Macula looks flat. So in the superior periphery, there are these kind of black streaks. They may be in the vitreous, it looks like. And then it looks maybe like a little fold up there, or that kind of clear line up there. That may be in the vitreous as well. I see it's overlying the vessels.
Excellent job. All right. So the retina itself looks normal here. What you were looking at there were vitreous veils. So these are all vitreous veils, and the dark areas at that superior part of the retina are also in the vitreous, like you said, and those are just shadows coming from the vitreous veils. What you can see here, which we couldn't capture in the optos, is there's a small tear that I mentioned earlier at the beginning of the case that was lasered in that right eye. Let's take a look at the left eye. Can anyone tell me what they see on the optos photo, color fundus photo of this eye?
John?
This is an optos color fundus photo. The left eye, media is clear. The disc looks pink and sharp. The vessels look within normal limits. In the macula, there's almost a circular lesion in the parafoveal region. It looks hypopigmented, as well as several similar lesions abutting the inferior arcades. The periphery looks flat to me. I don't know if that's some paving stone degeneration in the far periphery, superior-temporally, or if that's some atrophic holes, but otherwise that's what I see.
All right, good job. So actually, the retina itself looks fairly normal centrally. Those are just reflections of the nerve fiber layer that you oftentimes see in normal young patients. But you know what I just wanted you to comment on is just the laser scars inferiorly and infratemporally, and a little bit more far temporally here, associated with the localized retinal detachment that I mentioned earlier in the case. So the retina actually, doesn't look that remarkable. It looks fairly normal. It's difficult to see any problems associated with it in this photograph. So let's try looking at autofluorescence photographs. Let's see here. Can anyone tell me what they notice, if anything, in these autofluorescence photographs?
See if I know.
Nicole, what do you think?
These are autofluorescence photos of both eyes. Honestly, I think overall they look normal. The media seems kind of hazy on the right eye there. Doesn't seem as clear, but overall they look pretty normal to me.
Excellent job. Yeah, they look pretty normal. We don't really see very much in either eye here, so they don't look particularly pathologic in any way. So we decided to do a little bit more imaging, and so we did infrared imaging, and here's our infrared. Can someone tell me what they see, if anything, here on infrared imaging?
Ben?
Oh, hey. So basically, you have areas of hyperintensity surrounding on the fovea and perifovea and parafovea bilaterally.
Okay, excellent. So there are these focal areas of hyperintense signaling on infrared imaging in both eyes. Actually, you notice them in both on the right and the left. These are abnormal, and we don't normally see these in normal eyes. So what's going on here? We got an OCT, on the OCT, the retina itself looked okay in terms of its contour. There's no intraretinal or subretinal fluid. But if we take a section through one of these lesions, okay, one of these lesions we saw in infrared imaging, we noticed these focal areas that we just talked about here of hyperintensity signaling coming from the choroid, actually. So posterior to the neurosensory layer. And so we see the same thing in both eyes. Here is a left eye, and a normal foveal contour, normal retina layers. But if you take a section, a cross section through one of these lesions, again, you notice this, again, hyperintense signaling. So what's going on here? So let's summarize what we know so far. So we have a 13-year-old female, okay, with a history of localized retinal detachment, who presents with an exam significant for nodular iris excrescence in the left eye, all right, and multiple areas of focal hyperintensity of the uveal tract in both eyes. Any differential ideas, guys? Anyone?
What would be the differential? Yeah, what would be the differential for an iris nodule?
Sarcoid.
Mm-hmm. What else?
JXG.
Mm-hmm.
TB.
Yep.
Neurofibromatosis. Metastasis from that adenocarcinoma that she had taken out.
Okay, great. Those are all good attempts, but given the constellation of symptoms and the nodule that we saw in the iris, I actually would put, when I think about an iris nodule, I would put, neurofibromatosis up there on the top of my list. So that made me think about, when we think about, kids and ocular cutaneous conditions that have systemic manifestations, what comes up in my mind are phacomatoses. And I know you guys probably talked about these quite often. And so I think it's kind of worth going through and making sure that we don't miss any of them. These are favorites on the OCAPs. So I'm not going to go through all of them in high detail. I'm just going to, summarize. These are all in your BCSC. Obviously, we're probably all thinking NF for this patient, but we should also consider these other phacomatoses, okay? I'm going to go through, some of these are all directly from your the BCSC series. And so you should all be able to, have these pictures in mind when you're thinking about a child with systemic manifestations of neuroocular cutaneous disorders. So tuberous sclerosis, classically, you'll get these ash-leaf spots, adenoma sebaceum, you have these intracranial classifications, and you have also these facial angiofibromas. The VHL disease, you have these retinal capillary hemangioblastomas. Sturge-Weber, you have your port wine stain. You also have these kind of vascular malformations. You have with cortical atrophy. You have these, they call it the tomato ketchup kind of diffuse choroidal hemangioma. And then you also have glaucomatous disc cupping, especially on the same side as the port wine stain. Ataxia telangiectasias, you'll have these abnormally dilated tortuous vessels in the interpalpebral space. Incontinentia pigmenti, you can have these kind of erythematous and bullous lesions on the hand, or on the skin, I should say. You have hyperpigmented macules. You also have kind of a ROP-like presentation on the peripheral retina. And then the Wyver-Mason, which is also called racemose angioma, all right? And you have these kind of shunts from arteries, from left to right shunts with arteries to veins without intervening capillaries. So these are all possibilities of phacomas that we should always think about when we're seeing a child with systemic conditions and ocular cutaneous manifestations of them. So obviously our working diagnosis was neurofibromatosis. So we're going to talk a little bit about this condition, and then we'll go into it a little bit more. It's a relatively rare autosomal dominant condition. It's a hamartomatous condition of neural crest origin. There are two types, 1 and 2. Type 1, you get these multiple neural tumors on the skin, within the body, pigmented uveal tracts, Lish nodules, which is the name of the type of nodule that we talked about on anterior segment photography earlier. Type 2, you have these bilateral acoustic neuromas, schwannomas, spinal cord, and ependymomas. You also have early onset PSCs, a classic kind of OCAP question there, combined hamartoma of the retina and RPE. Type 1 is caused by mutation in neurofibromin, which is on chromosome 17. Type 2 is in Merlin, and that also causes tumorigenesis. There's variable expressivity in affected individuals, some with only a few tumors, or with hundreds or thousands. In 1988, the NIH came up with a clinical diagnostic criteria for neurofibromatosis, which is what we still have today. And these are all pictures directly from PCSC, and I'm sure all of you guys know these already. You've probably seen questions on these. You have your cafe-au-lait spots, plexiform neurofibromas, you have axillary freckling or inguinal freckling, you have optic nerve glioma, first degree relative with confirmed NF1, 2 or more Lish nodules. In our case, our patient only has 1, but classically, they usually develop many more of them in the prepubertal stage, and that's what's been noted. They also commonly will have sphenoid dysplasia, cortical thinning in the long bones, and other distinctive osseous lesions. Any 2 of those things will give you a clinical diagnosis of NF, and that was defined by the NIH. Ocular manifestations we kind of already talked about. Plexiform neurofibroma is a classic one. We'll talk a little bit more about that later. Intraorbital neurofibromas, Lisch nodules, which we already saw, and then they also are at high risk for glaucoma as well, especially when they have on the same side that you'll see a plexiform neurofibroma. They also another ocular manifestation is optic nerve gliomas and sphenoid wing dysplasia. One thing we don't always talk about with these patients is their systemic manifestations. Obviously, we're ophthalmologists, but they can have a lot of issues systemically. Peripheral nerve tumors, pain, disfigurement, neurologic defects. They have local organ compromise, and they can actually, the leading cause of mortality in these patients is malignant transformation, and they can actually, the tumor can degenerate into a malignant peripheral nerve sheath tumor. So the finding we were talking about earlier with these kind of interesting hyperintense lesions on infrared imaging have been noticed, and it's been reported many times in the literature actually. It's been reported in up to 100% of cases of patients that were seen in this condition. On confocal infrared, the choroid is thought to be the source of the signaling, and it's thought to be due to melanin, higher amount of melanin within the choroid than one would expect in those focal lesions. Now, those focal lesions are actually thought to be nodular melanocytic nodules, and that's it's very similar to cafe au lait spots that you see on the skin. But in this time, in these patients, you can also see it within the uvea, the uveal tract. And so on FA, they usually don't show up, and that's because they're deep to the retinal vessels and choriocapillaris. They're also, it's also been seen on histology in patients. I don't know why how they got the histology, but they did, and they also saw that these seem to correspond to choroidal neurofibromas and choroidal nodules. And we in Dr. Reynoso's clinic, we've actually used OCTA, and we've documented overlying choriocapillaris atrophy adjacent to these nodules. So that's an interesting finding that I don't think it's been reported, and actually Dr. Marine Adia has submitted a publication on that. So let's get back to our patient. The patient, since she was having these breathing difficulties that I brought up earlier, it was decided that she should probably get some imaging of her abdomen and chest. So they got a CT abdomen chest with contrast, and this is what was found. All right, this is the CT coronal image of her abdomen and chest. And what was noticed was that she had a large retroperitoneal mass, okay, involving the mid-thoracic spine, and she also had displacement of the trachea, aorta, and inferior vena cava. They biopsied the mass lesion, and they found it was a plexiform neurofibroma. And it's a classic lesion in patients with NF. Genetic testing was done, and it confirmed that she did have mutations in NF1. The case was then reviewed by her entire team, including pediatric surgery, orthospine, hematology, oncology, and the mass lesion was deemed inoperable. So the question then is, how would we manage this inoperable lesion in this patient presenting with neurofibromatosis? Well, there's no real accepted universal standard of management for these patients, okay? The histology does not really predict clinical behavior, all right? And the lesions are usually, most of them are observed, especially if they don't change. Treatment is usually directed towards a relief of symptoms such as surgical excision of cutaneous plexiform neurofibromas in patients who may where it may be amblyogenic. Optic nerve glioma, surgical excision, if it's stable, usually it's observed. If it's causing disfigurement or it's threatening the optic chiasm, they can excise it. Usually they don't they're not able to get it all, but just kind of surgical debulking. Until recently, the therapy for this was just that, surgery. Unfortunately, surgery doesn't fix it all because you can't get it all. And there's a high risk of plexiform regrowth, and obviously risk from the surgery itself. But recently there's been a new kind of development in the treatment of this disorder, and that's the introduction of a new class of medications called MEK inhibitors. I'm going to spend the last few minutes talking about these, and it's kind of changing the management of these tumors. So NF1 is a tumor suppressor, okay? It kind of stops the activation of an oncoprotein called RAS. Okay, so RAS is activated when you have this receptor tyrosine kinase that gets activated, assembles a bunch of other proteins, and leads to the basically the cell cycle reentry of a cell, causing growth, proliferation, and malignancy. So there have been a bunch of people and companies who've tried to attack neurofibromatosis by attacking this kind of cascade. A lot of them have tried to use, BRAF inhibitors. Those failed. A lot of money and time was spent on those. But MEK inhibitors recently have been tried, and there have been some clinical trials that have shown promising results with MEK inhibitors for both low-grade gliomas and inoperable plexiform neurofibromas. In particular, one of them, selumetinib, has been shown to be pretty, consistently effective for patients with plexiform neurofibromas that are deemed inoperable. There was there's a small clinical trial of selumetinib in these patients. It was done in 2016. It was published in the New England Journal of Medicine, where they had 24 children, with all of them with inoperable tumors, just like our patient, and had a median tumor value of over a liter, deemed inoperable. Okay, and they received the medication, and they all had confirmed partial responses, which was defined as decrease in tumor volume by at least 20%. Over 70% of the patients responded to it, and that was higher than in any other MEK inhibitor shown here. And so they did a phase 2 clinical trial, and they essentially found that they got the same result. So this drug was given orphan drug status by the FDA, and now it's available for treatment for NF1. But obviously these are powerful drugs, and they have toxic side effects. So I'm going to just quickly go through them. I know we're running out of time. MEK inhibitors can have toxic effects, especially in the eye. Most of the common toxicities reported are dry eye, periorbital edema, retinopathy. Typically happens early on when the patient starts treatment. On MAC-OCT, you might see intraretinal cystoid or edema or subretinal fluid, kind of like what's being shown in this patient that started with the medication. And it's usually associated with minimal symptoms, and usually they don't usually stop taking the medications unless it's visually significant. And if it is, they usually respond by stopping the medication, and usually the fluid goes away. Other symptoms or other signs or symptoms of retinal dysfunction have been seen with taking MEK inhibitors, such as vein occlusions and bilateral retinal detachments, but those have been relatively rare in less than 1% of cases. So with these new class of medicines, the recommendation is that these patients get ophthalmic evaluation at the start, before they start the medication. When they start the medication, 1 month in, and then every 3 to 6 months after that, just to make sure that they don't develop any of these symptoms, even though most patients that do develop retinal complications do so within the first few weeks of study. So our patient will be starting that medication, selumetinib, and we will be following her closely as she starts that medicine, and we'll be watching to see if her tumor shrinks. Obviously, the size of that tumor is concerning, and we're concerned not just about her eyes, but the rest of her body. I think that's it. I think I just made it to 6 o'clock. These are my references, and I can take anyone's questions.
Where's presentation?
Oh, thanks, Dr. Weiss.
Tommy, can you go back to the color fundus photos for just a sec?
Sure. Which one, the right eye or the left eye?
It doesn't matter. It's a little bit, I guess you can't really see it well there. But
yeah.
on the optics, if you magnify the pictures, you can actually start to see a little bit of that hyperpigmentation on the macula, and it kind of corresponds to the areas of hyperreflectivity we saw on the infrared. So I think with time, these become more and more pigmented. And one of the terms that has been used for these are retinal cafe au lait maculas. So I think that's kind of what we're seeing, and we really only saw it initially. I mean, on exam, you really cannot see it.
It's very difficult to see it.
Yeah, you can't see the hyperpigmentation. But we were doing a baseline OCT for her since we knew she was going to get started on the MEK inhibitor, and that's when we noticed the hyperreflectivity on infrared. So it's a pretty interesting case. Hopefully she won't develop any retinal toxicity.
Yeah.
I think associated with this, she has some issues with her vitreous, and the vitreous scales and the retinal detachment is probably not associated to NF1. Just another finding that fortunately we caught early and we were able to laser, and she's pretty stable. We laser about 5 years ago, and she's been stable since then.
Yeah, I try to look in. Yeah, thanks. I try to see if there's any reports of retinal tears, detachments, or vitreous abnormalities in patients with NF1, and nothing really came up. That was kind of interesting.
Yeah, to be honest, I think I glazed over that part in the BCSC where they talk about these choroidal lesions that you see on the infrared, but apparently they're well documented and present in the majority of patients with NF1.
Yeah, I guess you guys are going to be taking your OCAPs. I think that's going to be like one of the trick questions they might put on BCSC. Exactly, because it's in the book. If you read it, it tells you that they can have these cafe au lait like melanocytic lesions in their choroid, in the uveal tract, and you can't see it on fundus examination. You have to see it by infrared. And I was shocked because I don't remember reading that, but it's actually in the book. So they could show you a lesion like I just showed you and expect you to know that, oh yeah, that's probably NF1. It's not just cafe au lait spot on the skin. But you can also see it in the uvea. So it's I think that's like a great trick question that the BCSC can throw at you guys.
With time, you do see the hyperpigmentation on the retina, though. Like most adult patients, you'll actually see it on exam as well. Just to clarify that. But yeah, that was a good presentation, Tom.
Thank you. Stop sharing.
Alrighty, guys. Now that we're mentioning OCAPs, just wanted to let you guys know for OCAPs 2021, they're actually gonna give us 4 days to take OCAPs instead of just that 1 day. So eventually, the good news for attendings is that we're not gonna have to cover OCAP call anymore. And then for residents, we have to work on making sure call is covered when you schedule your OCAP exam. So we'll talk about that a little closer to OCAPs, but now you'll be able to pick between 4 days to take your OCAPs.